Thank you, Rupert and Sarah, having me to talk about our ketamine research and review article we've written recently. So this is the title, Effects of Ketamine on Rodent Fear Memory. And I'd like to acknowledge my colleagues and co-authors who contributed to this review article, especially Dr. Radford. We've been working on ketamine project together using preclinical animal models to look at ketamine's effects on fear memory as well as like physiological responses. We are particularly interested in ketamine as a battlefield analgesic because ketamine is widely used in the military after traumatic injury and traumatic shock. So we were particularly interested in what would the ketamine administration in the peri-traumatic period influence long-term psychological effects, including PTSD. So that was the question. So depending on when we administer ketamine, I think we can look at different aspects of ketamine on like fear memory consolidation or like fear memory reconsolidation or extinction, which I will talk about a little bit more later. I have nothing to disclose. I have no conflict of interest. So this is purely based on my opinions and my colleagues. As you know, ketamine is an NMDA glutamate receptor antagonist. There are several medical uses for ketamine, as you know, dissociative anesthetic at higher doses. At lower doses, ketamine can produce powerful analgesia and sedation in patients. At antidepressant doses, which are relatively low, ketamine can have some beneficial effects on treatment-resistant depression and suicidal ideation. And recently, ketamine has been tested as a potential treatment for PTSD. Ketamine has some side effects as well, including agitation, confusion, and hallucinations. So those are related to like dissociative symptoms in humans. And animals will also show dissociative stereotypic behaviors after receiving ketamine. And we can quantify those stereotypic behaviors in animals as well. Ketamine can also increase blood pressure and muscle tremors at higher doses. Ketamine in the military, particularly because ketamine is a commonly used battlefield anesthetic and analgesic. And ketamine can be used in emergency surgery in war zones. Since the ketamine has a high safety ceiling, ketamine doesn't suppress respiration or disrupt the hemodynamic stability. It can be safer to use in trauma settings instead of using opioid. So ketamine can have a beneficial effect in soldiers with a traumatic shock and injury who are at risk of hypotension and severe blood loss. So we are interested in peri-traumatic ketamine administration on PTSD symptoms. So this is a scenario in the battlefield, soldiers can get injured and then they are receiving ketamine as a battlefield analgesic drug. But since the ketamine can produce some side effects, including dissociation and hallucination, we were interested in whether ketamine will increase or decrease PTSD symptoms later. So that was the main question we had. But the difficulty of studying battlefield ketamine effect in humans or service members can be difficult because of uncontrollable environment and many confounding variables that we cannot really control in a human subject, in human studies. So we used the animal model of PTSD, specifically looking at fear memory. So this is called auditory fear conditioning in rats, as you probably are familiar with. If you look at the diagram on the left, we can pair auditory tone with mild foot shock to create a fear memory. This is associative learning. So we can place the rat in the conditioning chamber and play the tone, and at the end of the tone, we can deliver mild foot shock. So that can be unconditioned stimulus. And then animals will quickly learn the association, and later animals will show conditioned response to conditioned stimulus, which is the auditory tone. So here, in C, we could put an animal in a novel context, which doesn't really generate fear response, but we can still measure a cued specific fear using the same auditory tone. Or we can, put animals back to the conditioning chamber to measure context fear. So we could distinguish context fear and cued fear using this auditory fear conditioning paradigm. So this is a simple and robust model to study different aspects of fear memory in rodents, and we are using rats for our study. As you know, there are different stages of fear memory. There can be fear memory consolidation and reconsolidation and extinction. So we can look at those different phases of fear memory using this paradigm. When we wrote this review article, we were particularly interested in several factors that can contribute to ketamine effect on fear memory. I think one of them was timing of ketamine administration. So we could administer ketamine at different time points. For example, before fear conditioning. So that could be looking at prophylactic effect of ketamine, depending on how early we administer ketamine before fear conditioning. Or we could administer ketamine right after fear conditioning, while animals are supposed to go through fear memory consolidation. Then we are looking at trauma analgesic effect of ketamine on fear memory. Or we could give a ketamine later, like long after fear learning. Depending on when we give a ketamine, it could be a treatment angle for PTSD if we pair ketamine administration with extinction training. So that can be like a cognitive behavioral therapy in humans. So there are different time points that we could administer ketamine and look at ketamine effect on fear memory. Here, I'd like to point out differences between the route of ketamine administration. As you can see on the left picture, patients usually receive a continuous intravenous ketamine infusion at low doses for pain management or anesthesia. With IV ketamine, usually bioavailability is 100%, but different routes of administration can reduce the bioavailability of ketamine. We found a major gap between clinical and preclinical studies of ketamine, which was a route of administration. Most of the preclinical studies injected ketamine with the intraperitoneal route. So as you can see on the right picture, a large dose of ketamine is injected to the intraperitoneal cavity at once. So that creates a big difference compared to a continuous infusion in humans. Therefore, pharmacokinetic effects of IV infusion and IP injection of ketamine are different. And that's what we found in our study. This shows the drug metabolism, like a hypothetical curve. As you can see, bolus versus infusion of, let's say, ketamine. And y-axis shows the plasma drug concentration, and x-axis shows the time. And I just drew the red line. So that can be a single bolus administration, which elevates ketamine levels very quickly and then decreases relatively quickly. But if we do continuous infusion of ketamine, then drug levels will gradually rise and then reach the stable plateau. In our infusion study, usually we combine bolus administration and IV infusion. The reasoning is that way we can quickly raise the plasma ketamine concentration and then maintain with the continuous infusion. So that was the strategy we have taken. For this review article that we've written, we had several inclusion criteria, which were rodent studies only, and we looked at sub-anesthetic doses of racemic ketamine. That means studies that tested the anesthetic dose of ketamine were not included, and we looked at studies that utilize fear conditioning and some of the stress paradigms. And we included the male and female rodent studies, and with only single ketamine administration. So we didn't include the studies that used repeated ketamine administration. So let me quickly just go over the table we put it in the review article. So these are the studies that reported increased fear memory after ketamine administration in rodents. There are 5 studies, and as you can see, all of them used the IP injection of ketamine. And then they have manipulated the different phases of fear memory with the ketamine administration, including consolidation, reconsolidation, and extinction, as shown in this column. And as you can notice, there are 2 studies that use the ketamine one day before the contextual fear conditioning or situational reminder. So that could be like a prophylactic use of ketamine, but also those studies are, in my opinion, a little more difficult to interpret the data. The reason is we are looking at like long-term effects of ketamine for those studies. There are also studies reporting reduced fear memory after ketamine administration. These are the studies, and results were quite complicated. The 3 studies highlighted in the middle, those are the ones tested the prophylactic effect of ketamine by injecting ketamine before the contextual fear conditioning, like 1 week, 1 month, 1 day, or 1 hour before. And rest of the studies used the ketamine relatively close to the experimental condition. And one study, Ito et al., they actually tested like observational fear, which is a little different from a classical fear conditioning paradigm. And 2 studies shown on top and bottom, and they use the ketamine to test the differences between trace fear memory and delay fear memory. And they found ketamine affected trace fear memory rather than delay fear memory. So the conventional paradigm that we are using is called delay fear conditioning. So there are like a mixed result depending on the paradigm and like timing and doses of ketamine administration. But overall, these studies reported reduced fear memory after ketamine administration. But as you notice, all studies use ketamine injection, either intraperitoneal or subcutaneous. And these are studies showing mixed results with the ketamine. And Radford et al. Studies are our studies that we published. And as far as I know, our group is the only group that utilizing analgesic doses of ketamine infusion in awake and freely moving rats to look at fear memory. So I highlighted those studies here, and particularly the Radford 2018 study, I'd like to discuss a little bit more, because we tested different routes of ketamine administration in that study with IV infusion or IP injection, and we found differential effects on fear memory. This is a model that we are using. We are using rats with indwelling catheters implanted in the jugular vein. This is the PET CT image of a rat. Actually, this shows a glucose uptake in the hyaluronic gland around the eye and then heart. And the CT scan shows the skeletal the structure. And you can see on the back of the animal, there is a catheter exit port, and there's a tubing connected to the jugular vein. So arrow shows the tubing inside the body, and tubing is connected to the jugular vein. And that's how we can do continuous ketamine infusion in freely moving rats, because rat is tethered in the infusion chamber and they can move around. So we tested the different doses of ketamine, and we studied fear memory after ketamine infusion in these animals. Another advantage of using indwelling catheter method is repeated blood sampling. So we can draw blood from the same catheter without stressing or anesthetizing animals. So we can analyze stress hormones or other biomarkers present in the blood. So this was an experimental design that we used for that particular study. So fear conditioning was happened on day 0, and animals had a time to acclimate and habituated. Right after fear conditioning, we delivered a 2-hour ketamine infusion, analgesic dose of ketamine infusion, and 2 days later, we started the fear memory testing on day 2, 3, 4, shown here. On day 2, we started with fear memory retrieval, followed by within session fear extinction. On day 3, we repeated fear extinction test to look at fear extinction retrieval. And on day 4, we placed animals back to the conditioning chamber to measure fear renewal to the context and to the single conditioned stimulus. To compare with the bolus ketamine administration, we did a separate experiment with the ketamine injection. 10 milligram per kilogram dose of ketamine was injected right after fear conditioning, and then we also tested the fear memory in the same time point. Here, this shows IV ketamine infusion enhanced the fear memory. So we are looking at fear memory consolidation because we gave a ketamine infusion right after fear conditioning. So this shows ketamine infusion enhanced the fear memory consolidation, and as a result, animals are showing increased freezing followed by delayed fear extinction. So we tested 3 different doses of ketamine here, 2, 10, 20 milligram per kilogram. And the medium dose, which was a 10 milligram per kilogram, produced a maximum effect, as shown on top of the graph. But animals were capable of learning extinction gradually, but overall, there was a significant effect with the medium dose. And as you can see, the ketamine doses are showing inverted U-shape compared to the saline control group. And when we repeated the same testing on day 3, animals learned the extinction faster because they were already, they already learned the extinction in the previous day. But still, we saw a similar pattern with the ketamine groups. So this shows ketamine infusion enhanced the fear memory and also delayed the fear extinction. That was surprising to us because we expected the other way. So when we inject the ketamine after fear conditioning, we saw differential effect. So on day 2, when we tested the animals on the same extinction paradigm, there was a trend of reduction in freezing with the ketamine animals, 10 milligram per kilogram. and that difference was significant on day 3. So it looks like IP ketamine injection reduced the fear memory and also facilitate the fear extinction based on this testing paradigm. So actually, this finding is somewhat similar to the paper published by Gurjanti group in 2017. They injected the same dose of ketamine after fear conditioning, and then they found facilitated the fear extinction, especially on the second day of fear extinction. The results are somewhat similar with the same route of administration. As you know, there are many studies showing glucocorticoids are important in regulating fear memory. For example, post-fear conditioning administration of glucocorticoids modulate fear memory consolidation in rats based on these studies. Also, glucocorticoids may produce opposite effects on fear memory consolidation and retrieval, and amygdala can be a key brain region for this mechanism. So when we measure the stress hormone levels, which is a corticosterone in rats, we saw increased cortisol levels after ketamine infusion. So left graph is without fear conditioning, right graph is with fear conditioning. So compared to baseline or saline group, ketamine infusion dose-dependently increased cortisol levels, and that was a very robust and consistent finding. So probably HPA axis is activated with ketamine administration, and that could influence fear memory formation. So this is the putative molecular mechanisms we came up with. Obviously, it's a lot more complicated than this, but we think ketamine administration can stimulate HPA axis and then increase the stress hormone levels, can travel back to the brain and influence the key brain regions, including hypothalamus, amygdala, and hippocampus. And the bottom diagram shows the like a synaptic cleft, and ketamine can also inhibit NMDA receptors in GABA inhibitory interneuron or presynaptic or terminal or glutamatergic neuron, and therefore like disinhibiting the glutamate signaling. So the end the result would be increased glutamate signaling by ketamine administration. And there are other molecular there are other targets such as BDNF, like ERK, and other transcription factors also playing a role on ketamine mechanism. So this is a table I put together, try to summarize what we found and what we think is going on with the ketamine administration. And I distinguish the ketamine effect based on intravenous infusion, in our case, usually 2-hour infusion, or IP bolus injection of ketamine. So ketamine produces a very distinct dissociative or stereotypic behaviors in rats, but with the infusion, dissociation is very mild. We don't really see dissociation except that initial the bolus dosing, but with IP injection, dissociation effects can be stronger because large doses going to the body at once. Sedation and analgesia, we can see with the ketamine infusion clearly, but with the IP injection, sedation and analgesia can be also weak. And court elevation, because of the duration of ketamine infusion, I think the duration of court elevation is longer with infusion compared to IP injection, because the court levels rise and come back to baseline very quickly after the ketamine administration. For drug metabolism, for the same reason, IV infusion can maintain steady state ketamine, plasma ketamine levels, whereas IP injection can produce a rapid peak and trough of ketamine, the metabolism pattern. Because of this, with the IV infusion, we are bypassing hepatic metabolism and probably like producing more ketamine effect, whereas with IP injection, probably we are producing more metabolites of ketamine, and those metabolites can also contribute to some of the ketamine effects. Potential mechanism, because we are delivering a lower dose ketamine over 2-hour period, that could be mainly blocking NMDA receptors with the infusion condition, but with the IP injection, it could be non-specific due to a high concentration of ketamine at the beginning of the injection. For fear memory consolidation, when we compare the infusion versus injection after fear conditioning, we saw differential effects. So we think infusion may increase fear memory consolidation, whereas IP injection could decrease fear memory consolidation. So in summary, we found multiple factors such as a route, duration, dose, and timing of ketamine administration can be important on like rodent fear memory studies. And also individual differences in stress reactivity may also contribute to ketamine's effect on fear memory, which is also relevant to the clinical situation. And multiple brain regions and molecular pathways are likely involved in ketamine's action, including HPA axis. For the future direction of ketamine research, I think considering clinically relevant paradigm would be important, such as a dose and route of ketamine administration, and also stress versus a non-stress condition when we conduct research. We found sex-related differences in ketamine's effect on some of the behavioral outcome measures. So looking at male-female differences can be important, in light of PTSD symptoms. And I think important thing is the communication and collaboration between preclinical and clinical researchers to enhance translational value of ketamine research. And I'd like to acknowledge the funding source for our research, Tri-Service Nursing Research Program, and university grant. And I think that would be it.
Great, thank you very much indeed, Kwang. That's terrific. We haven't got any questions yet coming in through the Q&A, so please do put your questions in through the Q&A just for this first part. I'll kick off, and then maybe Sarah's got some questions just while you're thinking. So can you just tell us whether your colleagues from the the Centre for Traumatic Stress, whether they say that soldiers who are given ketamine are and presumably this is very shortly after they've had some traumatic event, whether they are more likely to get PTSD or less likely to get PTSD. Can you say anything about that?
Yes, that's a good question. As you probably know, there are some studies looking at military service members that received ketamine or different analgesic drugs in the battlefield or in the theater. But again, I think the results are mixed, and it's not very clear. Some studies found like no effect on PTSD, but some studies using civilian, like a population found like increased PTSD symptoms, but also there were differences depending on when they have looked at PTSD symptoms, whether that was like acute stress disorder or like PTSD. But I think the difficulty is there are so many uncontrollable variables, and also it's just difficult to tease out ketamine only effect in that situation.
So I'm tempted to say that of course, in the animal work, there are lots of controllable variables, but you've ended up not, there are so many variables that are possible, that can possibly be altered, that we've ended up with a situation where it's still hard to make conclusions that we can use clinically.
Yes, I think that was the main advantage of using animal models, so we can really, have a good control on those variables that we are interested in. So,
okay, thank you. We've got some questions coming in, and I think it might be useful for us to go back to the graph of your IV experiment, if you could take us back to that, because we've got a question here. Yeah, that one. Yeah. And it says, how are you interpreting your findings that ketamine effects are increasing fear memory versus preventing fear extinction? So can you just talk us through that graph again? So are you saying that, or the previous one, are you saying that the increase in fear memory is what you're seeing in this top 10 milligram line here, and it's really the increase at block 2? Is that what's driving this?
yes. So this was the session that we tested animals with repeated presentation of conditioned stimulus. So each block is the average of 2 tones. So we played 12 tones in each session, and then measure the percent freezing in each group. So I think the first 2 blocks, usually animals are like showing higher freezing, greater freezing, even for control animals. I think that's why probably there was a like ceiling effect. So although animals that received the ketamine showed greater freezing, I think because control group animals were exhibiting significant level of freezing, probably we couldn't really see the statistical difference. But while animals are showing extinction, as shown in this solid line, and then it has become clear the ketamine group animals were still showing increased freezing. That's what we are seeing here. So does it answer the question or not?
The question was about fear memory versus preventing fear extinction. So yes, I can see here that it's preventing fear extinction, isn't it?
Yes.
Yes. Sorry, if I can follow up to that question. And I think, Kwang, that's what you said before, right? You would have expected the opposite effect, like the ketamine would have like increased the fear extinction, and reduce the fear memory. Do you relate these to the route of administration and, for example, like the long IV infusion compared to like the bolus? Is the point you were making after these, or how would you explain this discrepancy between your hypothesis and your result?
Yeah, I think that could be one of the possibilities. As I talked about, there are so many differences between continuous infusion and bolus injection. So that's why I think probably the receptors are being targeted are probably different, and then the plasma drug levels are different. So
okay, we've got another question about sex differences. Can you say what differences did you see between the sexes? I mean, this is obviously in the review rather than your work.
Correct. So sex differences in ketamine effect, we are still conducting research, and so far we are seeing differences in specific dissociative stereotypy after getting ketamine. I mean, like between males and females, and also we are also seeing differences in like anti-nociceptive response after getting ketamine. And we are also looking at fear memory in female rats as well. I think the overall findings are similar. Female rats were also showing increased freezing after getting ketamine infusion, but there may be some differences in like a dose response. So I think we found the dose response curves were slightly different between males and females, but overall, you know, the overall findings were similar.
Okay, thank you. There's an obvious analogy here about the routes of administration that we use clinically, the effects of intravenous versus intranasal or oral ketamine, especially in patients with trauma history. So I think that's that's less of a question and more of a comment from Doug Lira.
Yes, Kwang, I was wondering, because you started like your talk when you were talking about, the analgesic effect of ketamine in the battlefield. I was wondering, like, the dosage that you tested in your animal work is mostly like the equivalent of an analgesic dose, or where are you standing on that?
Yeah, that's a good point. So when we started, ketamine work in rats, we couldn't really find IV ketamine doses, that produce reliable analgesic effect, because as you know, most of the animal studies were using ketamine injection. So we were interested in IV ketamine administration. So we started with dose finding studies by testing different doses of IV ketamine, either with a bolus or infusion. So we established the range of ketamine doses, that producing like consistent or analgesic doses, and then we tested those doses. So in our hand, usually like 10 milligram per kilogram infusion dose produce consistent analgesic effect, and of course with a bolus dose, it could be lower, but the effect may be a little short lasting. So that was the first study we did. And we also looked at dissociative stereotype behaviors in animals, and like acoustic startle and pre-pulse inhibition behaviors as well. So we have a pretty good understanding on immediate ketamine effects on those outcome measures in rats.
Thank you.